So welcome back. We're all together again, once again, after a couple of years of further distancing. Welcome to our session. Wait, there's more hidden effects of highly effective modulator therapy. I'm Hannah Fahn from the University of Michigan, and this is Renee Clark from UC Davis. We have a jam-packed session today. We're going to start with an education committee update, and then we'll go into a patient story regarding reaction due to ETI, or otherwise known as Trikafta. And then we'll go into adverse effects with Dr. Saferstein. And we'll talk copay accumulators and matrix models. I know everyone's super excited to talk about that with Ms. Kirschenman from Billings Clinic. And then Dr. Fleischman from Concordia University, and we'll end things off with aging and hypertension, hyperlipidemia, and osteoporosis. So we'll start off with our education committee update.
All right, good morning, everybody. Hopefully everybody's awake. My name is Rebecca Pettit. I'm the PCF pharmacist at Riley Children's Hospital in Indianapolis, and I am the chair of the education committee and happy to give our update. We haven't been able to do this in quite a few years. So for those of you that don't know what the CF Foundation Education Committee is, it's a multidisciplinary group. You can see all the different specialties there. We actually just added a genetics counselor this past year, and our adult as well as pediatric specialists. It's a 3-year term, and if you're interested in applying, there's a call out every few years for the different disciplines that are rolling off. So I am rolling off this year, and Brittany Wright will be taking over for me as a pharmacist representative on the committee. So when you see that, if you're interested, definitely send in an application. This is our group. We've met via Zoom, so you can see the different representatives there and the different specialties there, so kind of a wide range of people. So what do? We ensure the quality of education materials that are available to people with CF families as well as CF care centers. So we review education materials that are submitted for the Education Committee seal of approval for accuracy, applicability, and appropriate reading level. We also help identify areas of the greatest need to prioritize those reviews and solicit authors if there's things that need to be added or created for the education. We also review the educational abstracts for NACFC and help improve access of education materials. So we did review some different materials since 2019, so this is kind of a few-year update. There was there is smoke, there's fire in your lungs about wildfires and CF, a screening tool, an updated herbal products information sheet, and some of the CF Rise quizzes were also approved and evaluated. So here's kind of the nice graphics of those. Those resources can be found on the MyCFF resource library, and there's also this resource guide that I sent out via the listserv. If you're having trouble viewing it, which I have gotten from a few of you, definitely contact CFF and they can help you with your password and things like that. They also do have a booth here in the exhibit hall, so if you have questions, you can also visit them there. And so, again, most of the resources are on MyCFF to go get, as well as if you want some print resources, you can request them from the foundation at that email there. Or you can order them on the website with the order forms there. And then you complete this order forms. If you have questions, definitely reach out to resources at cff.org. and they will respond to you. So how can you be involved with the different education? You can submit educational abstracts at NACFC, respond to needs assessments, surveys that come out via the listserv, notify the education committee if you notice that there's a resource on my CFF that is out of date or no longer available. Also distribute education to your CF patients in the CF community, as well as submit resources to the education committee for review. So you are all welcome to submit different resources from your center if you want that official seal of approval from the committee. All right, well, thank you for your time, and let me know if you have any questions.
Okay, thank you so much for that update. Okay, so we have nothing to disclose other than I'm a consultant for Wolters Kluwer, but that has nothing to do with the presentation today. We're going to go over various things, as I mentioned previously, as per our agenda. So here are our session objectives. You also can see these on your app. What we're going to have in terms of our structure, all of our speakers are going to go back to back and speak to make sure that we have time for each speaker to fulfill and complete all the talking and speaking that they have as far as all the information they've provided for you guys. And then we're going to have like this massive Q&A at the very end, because I suspect we're going to have a lot of Q&A given the topics at hand. So we've completed our education committee update. Now we're going to move on to a patient's story, of which Emily Bonnell has recorded her story, and I hopefully the technology will cooperate so I can play it. But Emily is an adult with CF, 25-year-old. She is a graduate of Michigan State University in advertising management and minored in Spanish, and is fluent in Spanish as well. Works for fitness influencers as assistant creative manager and a social media manager. She has a bunch of different hobbies, including going to the gym, reading, writing, playing video games, and snuggling with her 2-year-old cat named Rug. So now we will hear Emily's story.
Hi everyone, my name is Emily Bonnell and I am 25 with cystic fibrosis, and I'm here today to run you through my experience with Trikafta. So I started Trikafta pretty quickly after it was approved by the FDA. I was really excited about it and I was lucky to get to it really quick. So I got on the medication and the first couple of days were awesome. I noticed that my mucus was thinning and my chest felt like it was opening up. And I felt like the medication was doing exactly what it set out to do. So that was really exciting for me. And then on the 8th day, I noticed that around just one of my ankles, I had really small red bumps. They looked just like a couple of mosquito bites, like little tiny mosquito bites all around my ankle, but they were really, really itchy. And so my first thought was that I had bug bites, praying it wasn't pet bugs, and it wasn't. But that was the first day, and I noticed them, just kind of like acknowledged it. I think I took a picture of it on my phone and then moved on. The 9th day was when I woke up and the little bumps had spread from just one ankle to both of my legs, and they had started climbing up my legs. They were pretty big bumps, looked in the beginning just like mosquito bites, and they started kind of crawling up my legs. So they were on my ankles, my shins, my thighs, and they were super itchy, really, really itchy. So I called my doctor in the morning and they told me to just pause the medication and see what happened there. So once I paused the medication, I still had issues. The bumps didn't go away. They actually kept spreading for, I would say, like a day or 2 days after that. They started presenting on my arms. Same thing, just super red, super itchy, like the itchiest, scratchiest feeling I've ever really felt. They were really, really itchy. And they were broken out all over like my forearms and especially my thighs and my shins and calves. So I was hoping it would get better by the next morning. I was taking Benadryl and like Zyrtec, I think. But then by the next morning, it had actually spread to across my chest, and it was on my stomach a little bit, and then up my neck. So I went into work, and my boss was like looking at me like, "You're having some kind of allergic reaction. Like, this is crazy," because it was climbing up my neck. And I was like, "Yeah, I think it's just like a side effect of this drug I'm on." And it just kept getting worse. At that point, it had been out of my system. I didn't continue, well, it hadn't been out of my system, but I didn't continue taking it. But the rash just kept worsening and expanding and growing. So then by the middle or end of the workday, it had climbed up my face and was going kind of around one of my eyes. So it looked like red and blotchy and splotchy. And it was climbing up my face and gone around one of my eyes, and my face was like a little bit puffy, probably more due to lack of sleep than the rash, but it ended up climbing and going around like my eye and my chin and all up my neck. So I ended up going to my mom's, and I was having a lot of like chest and throat tightness as well. So from there, we made the decision to go to the emergency room, where I received epinephrine. They gave it to me through an IV pretty immediately when I got there. So that was very interesting, an interesting experience for me. But once I had the epi, instantly all of my hives like went away. When I was laying there, like they were almost like you couldn't even see any of it. And it was all gone. I like looked completely clear. But then when I went home, they put me on like prednisone and Zyrtec and Benadryl and everything. And when I went home, all of my hives were back, but they were kind of more dispersed and merged together, like splotchy. So that was concerning for me that it was potentially coming back, but I guess that was just a part of it, like getting out of my system. So whenever I would take like the Benadryl, they would go away and then they would come back. So yeah, that was my main experience with Trikafta. I did have to stop it, and the main concern was that at the time there wasn't any literature about that kind of reaction because the drug was so new and had just been approved by the FDA. No one was really sure if that was going to be a common reaction, if that was more of a side effect or more of an allergy. So we took a lot of time to make that decision, and then when the pandemic hit, retrialing kind of went on hold. So here I am now in 2022, looking back at retrialing the drug now and trying to figure out if that was a true allergic reaction or if it was kind of a sensitivity. So I'm working very closely with allergy right now to start the process of desensitizing myself to Trikafta to see if I can hopefully get back on it. But yeah, that was my whole experience with the drug. Thank you so much for having me today.
Okay, so Emily also provided us images regarding her experience with the rash related to ETI. As you can see, not the most pleasant for our patients. How many folks in this room have had patients who've had rash due to Modulator? Okay, so rash and CFTR modulators, the incidence has been reported up to 13% based on what's reported from package inserts with the varying numbers, as you can see here. It's been reported in data and literature case reports that the incidence is possibly higher in females, especially those using hormonal contraceptive therapy or hormonal replacement therapy. In most cases, not necessarily this case, rash would resolve in about 1 to 2 weeks. However, for some it can return. And then options for treatment for those in the room, like you guys have probably thought about discontinuation, first and foremost, using antihistamines, systemic steroids such as prednisone. Some folks do a short course, such as 5 to 7 days. Some do a longer taper, and then the addition of topical steroids and things like that to help alleviate the symptom. It should be part of CFT or modulator education before you onboard patients onto the medication for the first time. Hopefully you guys are incorporating that as part of education. I know I do. And as far as desensitization, it is a possible option for some patients. We should always assess feasibility of it. Is it possible to do? Do we have ability to compound? The logistics behind that. There are a few folks in this room, including those specifically at the University of Kentucky, have published on that, and should include an in-depth discussion with your patient and family about the risks and benefits of desensitization. There is limited data out there, and we'll kind of go over a few of the case reports that have been published. So we have some guidance, but there's still yet to be some more education and experience, so we're learning case by case. Various approaches have been used and reported. So folks have reported doing observed doses in clinic and then going home with medication at lower doses and titrating up. The use of antihistamine as part of the protocol to onboard or restart the medication, to restart ETI. Dose escalation, as I talked about in terms of titration, using, for example, a fraction of a tablet and then increasing accordingly over time, or even compounded aliquots. So this is a very busy slide, but more for if you guys wanted more detail. I'm not going to read all of this on there, but kind of focusing on the highlights. So back in 2019, Patterson et al. Reported a case report, 18-year-old, and then the desensitization that they applied used aliquots, using crushed tablets and cornstarch, and then dose escalated over 10 days until a target dose was achieved. And then in 2020, another publication regarding a 20-year-old female, and again, applying aliquot dilutions to achieve desensitization. Of note, this particular case used a hormonal contraceptive washout period. So discontinuing contraceptive for 1 month prior to desensitization, and then resuming 1 month after desensitization was achieved. And then the second case in the 2020 publication involved a 47-year-old female. And this applied the use of an independent pharmacy for compounding and a desensitization over 10 days to Tez-Iva, and then eventually transitioned to ETI, experienced a rash at that time as well, and then received systemic steroids, antihistamines to offset that. In 2022, there was a case of 2 individuals, a 48-year-old and a 37-year-old female. And in this case, they applied the use of using a titration or ramp-up dose of fractions of tablets over 8 weeks. One patient was tolerated up to a point of 1.5 tablets of the morning dose of the ETI, and then 1 tablet of the ivacaftor, and then the second patient titrated to full dose successfully. And Lloyd in 2022 for a 7-year-old female. This was the one pediatric case that had been reported so far, at least in this series. Used diphenhydramine pre-medication, a dose escalation every 3 days using fractions of tablets, and then finally achieved desensitization. Who in 2022 also reported a desensitization in a 24-year-old female. Again, using partial tablets or a number of tablets over time versus an aliquot method. And then in 2022, Chang et al. Described a young adult female or adult male who experienced a rash due to ETI, and it was about 9 days after. They decided to apply fraction of tablet to a certain extent, 1/8 of a tablet, which is interesting, with IV hydrocortisone, chloramphetamine, prednisolone, and incrementally increasing over 8 days, and once at a full dose, tapering that prednisolone, the systemic steroid. And then folks in Oregon, 2022, 49-year-old female. They developed a protocol, which we'll show you on the next slide, with weekly dose escalation from clinic to home, with home doses prepared by the patient with a duration of 23 days. So that is probably one of the more recent cases that have been published in the literature. And I commend all the authors of these cases because they've provided additional insight and experience for us to learn from. So for Emily, her plan was to apply this last case report in terms of their approach. And as you can see in table 1, proceeding with the outpatient desensitization plan, it'll occur over 23 days. And we've been collaborating with the allergy clinic. We actually have a allergy clinical pharmacist specialist who deals with desensitization protocols and compounding. So this person has been heavily involved in preparing that patient. And then the product base will be Aura Blend with a beyond date of 14 days. As an update, Emily has not started desensitization at this time yet, but we hope to in the near future. And as pharmacists and pharmacy technicians, we want to make sure that we think about the different aspects of desensitization. We want to make sure, first and foremost, that we co-produce a plan with our patients and caregivers regarding the logistics of desensitization, again, the risks and the benefits of it. Consider collaborating with an allergist at your center if you have that ability to do so. And then think about other concurrent medications that may be impacting that particular adverse effect. For example, hormonal contraception or other hormone therapy, considering possibly a washout period if that's feasible, and restarting later. And then the approach to your desensitization can be a wide range from fraction of tablet, depending on how severe the reaction was, to a longer-term titration using aliquots, which requires compounding. So some centers may have the easy ability to do it, some may not, and so exploring what your options are, if you can partner with a compounding pharmacy, or if your health system pharmacy is able to assist as well. And then in terms of the dose escalation duration, depending on the severity of the reaction and comfort level of your patient. And then using concurrent pre-medications such as diphenhydramine or systemic steroids, considering the use of an oral steroid taper during that titration period, and then tapering off the steroid. And then where you're going to be doing this titration, starting out with doses observed in clinic and then eventually hopefully transitioning to home. Is it going to be during an admission, et cetera? So some take-home points. We want to make sure first and foremost we partner with our patients and families, prepare them for the what if, and this is before we even start medication. So hopefully as part of the time that you spend with your families educating and providing that insight about that CFT or modulator that you're starting, that the possibility of rash is there, and then discuss what can be done once if that rash appears, calling the clinic office. These are the things that we would consider doing as part of in response to the rash. You want to make sure that it's not a surprise for your patients and families, and having that plan for the management of that adverse effect. Rash may not necessarily be a hard stop for future modulator use, and making sure that's discussed. Considering the severity of the reaction, feasibility of rechallenge, and then of course, really taking into the perspective of the person with CF and their caregivers about that rechallenge and what it will take to achieve that desensitization. And as we know from these case reports and from experience in this room, desensitization requires careful planning. And we have to, again, evaluate risk versus benefit. What is the best approach for my patient, for this particular patient, and the feasibility of all the logistics. And I want to thank Emily for sharing her experiences so that we can all learn in this room and help others. And I want to thank Linda Fitzgerald for parts of the composition and preparing for this session. All right. At this time, to keep things flowing. Oh, sure. I want to make sure we have enough time for all of our speakers. We have a lot of really good presentation information. We have Dr. Saverstein, who will be talking about adverse effects beyond the package insert. And she is coming to us from the hospital of the University of Pennsylvania.
Good morning, everyone. My name is Julie Saperstein, and I'm the adult clinical pharmacist at the Hospital of the University of Pennsylvania here in Philadelphia. Today, I'll be discussing adverse effects beyond the package insert for lexicaftor, tezacaftor, ivacaftor, which I'll be referring to as Trikafta for the remainder of the presentation. I have nothing to disclose for the presentation today. One of the most common questions I get asked during any given clinic day, as I'm sure you all have as well, is have you seen blank with Trikafta? On the slides, just a word bubble of some of the examples of side effects that have been proposed on the CF Pharmacist listserv or discussed by our patients and our clinicians, and I'll be delving into a handful of these further today, concentrating on those that have been published on in the primary literature, and throughout I'll be discussing different management strategies for how we can help patients navigating these side effects when they present to us in clinic. The first side effect that was published on in the literature was testicular pain with Trikafta. We know that 97% of males with CF are infertile due to a congenital absence of the vas deferens. Males with CF still have sperm production that's stored in the epididymis, but because of the lack of a functioning vas deferens, it's not ejected in the ejaculate, which leads to infertility. While the CFTR protein is abundant in the reproductive tract, there have been no reproductive ADRs that have been reported in our clinical trials for our modulators. That brings us to our first case series by Rotolo et al. That described 7 males across 5 CF centers that were aged between 17 and 39 years old that describes testicular pain or discomfort as occurring within 2 weeks of starting Trikafta. Description of the pain varied. Some described intermittent sharp pain, sensitivity to touch, or soreness, and also had accompanying abdominal pain, bloating, and difficulty urinating. Most had resolution of their pain without intervention within 1 week after symptom onset, and all had resolution within 3 weeks. Some attempted to treat their symptoms with over-the-counter pain relievers with varying efficacy, and all patients were eventually able to resume full-dose Trikafta, with one having a temporary dose reduction and another with a short-term holding therapy. While the mechanism of the side effect is not clear, the writers hypothesized that it could be due to restoration of CFTR function in the male reproductive tract, and this could have led to movement of previous mucus blockage in the testes. Because this has the potential to be a distressing side effect, it's important for us to include this in our counseling for patients with a male reproductive tract. And while we don't believe that the CFTR modulators have the ability to impact male fertility because of the inability to cause duct reformation, further research is still needed on the potential for modulators in general to impact reproductive health. So we need more information about this. And for our patients that are interested in family planning, consult to a fertility specialist is recommended. That brings us to our second case series published on cholecystitis occurring after Trikafta initiation. Again, we know that people with CF have an increased incidence of gallbladder and biliary tract disease. The incidence varies widely in the literature, but most are asymptomatic. CFTR protein is abundant in the gallbladder and biliary tree and is important for maintaining fluid and electrolyte homeostasis of the bile. When we have CFTR dysfunction, this leads to decreased chloride secretion, which causes the formation of a thick, viscous bile with reduced flow and impaired pH, leading to the accumulation of toxic bile salts, and this can increase the risk for infection, inflammation, and gallstone formation. We know that hepatic panel abnormalities, including increases in bilirubin, are a known adverse reaction for Trikafta. However, cholecystitis specifically was not included in the package insert. This case series describes 7 patients across 2 adult CF centers that had biliary colic after Trikafta initiation. 6 of the 7 patients were treated with a previous modulator before starting Trikafta, and 4 of the 7 patients had a history of asymptomatic cholelithiasis that was found incidentally on CT scan. Notably, the 3 other patients didn't have abdominal imaging available. After presenting with right upper quadrant abdominal pain, the patients were diagnosed with cholecystitis, and 6 of the 7 underwent a laparoscopic cholecystectomy, all being able to resume Trikafta post-op. And then for the 1 patient that didn't undergo surgical intervention because of a high surgical risk, they were still able to continue Trikafta throughout and had eventual resolution of their symptoms. The authors of this study proposed that restoration of CFTR function, this time in the biliary tract, led to improved bile fluidity, and this could have caused movement of pre-existing gallstones, leading to symptomatic biliary colic. So based on these cases, it's important for us to counsel patients to report any severe right upper quadrant abdominal pain after Trikafta initiation. And for those that report this, we should be ordering a stat hepatic panel and abdominal imaging and consider cholecystectomy in patients that are diagnosed with acute cholecystitis. The third topic that was published on in the literature described the incidence of hypervitaminosis A after Trikafta initiation. And because of decreased intestinal absorption and pancreatic insufficiency, people with CF are at an increased risk for fat-soluble vitamin deficiency, and therefore, as we know, supplementation with vitamins A, D, E, and K are a standard of CF care. However, excessive supplementation with vitamin A can lead to increased retinol levels, and this can prevent the reabsorption of cerebrospinal fluid and lead to increased intracranial pressure, causing secondary intracranial hypertension. We know from previous CFTR modulator studies that they may improve intestinal absorption and pancreatic function, and this was seen in both ivacaftor and lumacaftor ivacaftor. Recently, 2 separate papers were published describing 3 adolescent female patients that presented with papilledema and secondary intracranial hypertension. 2 of the patients were modulator naive, while 1 was switched from ivacaftor to Trikafta. Patients presented with symptoms such as headache, blurry vision, and tinnitus, and symptoms were reported within 2 months for 2 of the patients and within 8 months for the 3rd patient. Further examination revealed a lumbar puncture with elevated opening pressure, an eye exam with papilledema, and mildly elevated serum retinol levels, and all 3 patients were diagnosed with intracranial hypertension on CT scan. Treatment included decreasing the exogenous vitamin A supplementation, dietary modifications, and acetazolamide for all cases. And for the 1 case that presented with fulminant secondary intracranial hypertension, they had a hospital stay that also required IV methylprednisolone, furosemide, and a temporary lumbar drain. After appropriate diagnosis and treatment, though, all 3 patients ended up having improvement or resolution of their symptoms, and 2 of the 3 patients continued on Trikafta. The authors proposed that potentially Trikafta in these patients led to a significant improvement in intestinal absorption of their fat-soluble vitamins. This led to quick elevations of vitamin A, again, decreasing reabsorption of cerebrospinal fluid and leading to that increase in intracranial pressure. It's also proposed that patients that have a history of pancreatic insufficiency or a history of poor weight gain may be more likely to have these significant improvements in intestinal absorption after Trikafta and therefore may be at higher risk for this side effect. Based on this, it's important for us to make sure our patients have up-to-date baseline vitamin levels before starting Trikafta and make sure to encourage them to stay on top of their blood work and getting their levels rechecked regularly. Also, given that most of these patients had only mildly elevated serum retinol levels, it was proposed that perhaps the speed of increase was what led to this side effect, so it's important for us to trend these levels as well. The 4th paper described acne after Trikafta initiation. We know CF is associated with several different cutaneous manifestations, including aquagenic skin wrinkling, but acne is not specifically associated with a higher risk in people with CF. As Hannah mentioned before, rash is a known potential adverse drug reaction for our modulators. However, acne was not included on the package insert. It was reported in the new drug application for Trikafta as occurring in between 1% and 5% of Trikafta-treated patients, but because of that low incidence, it was not included in the package insert. However, as we know, this is something that has been commonly discussed by our patients in clinic and also discussed on CF social media platforms. That brings us to our case series by Hudson et al. That described 19 patients across multiple CF centers. They were aged 21 to 38 years old, and they reported new or worsening acne after Trikafta. Almost half of the patients had a history of acne before initiation, and most reported symptom onset within 6 months, but it was noted that the timing of initiation was limited to patient recall. And where data was available, the face was most commonly affected, but again, the information about location and description of the acne was limited because most of our patients were not seen by dermatology. The management of the acne also varied greatly, including over-the-counter topicals, prescription topical agents, oral antibiotics, and other orals such as spironolactone and isotretinoin. And 16 of the 19 patients reported at least partial improvement of their acne with treatment, and all continued full-dose Trikafta throughout. The authors of this study proposed 2 different potential mechanisms. The first, that restoration of CFTR function in the sweat glands of the skin, of course, led to alteration of salt content in the sweat, and perhaps this change led to a change in the skin microbiome, causing acne. This is analogous to the changes that we've seen in the CF lung microbiome, increasing in diversity after Trikafta initiation. The second potential mechanism is that perhaps a rapid decrease in sweat chloride led to an inflammatory response in the skin, also leading to acne. The third potential mechanism was not mentioned in the paper, but anecdotally has been proposed by patients and clinicians, is that perhaps there's a hormonal relationship or a hormonal off-target effect of Trikafta. This has been mentioned because some patients report cystic acne, and they've also reported other hormonally related side effects that they attribute to Trikafta initiation as well, but more research is needed to explore this link further. So based on these cases and our experience in clinic, we should of course be counseling patients on the potential for new or worsening acne with Trikafta initiation, and consider starting topical or oral therapy depending on provider comfort, and consider consult to dermatology for further evaluation and treatment, especially for severe cases or for those that are refractory to initial therapy options. And the final topic that I'll be going through today is mental health concerns related to Trikafta. And in my opinion, these are the most commonly described off-target or side effects that are not included on the package insert, and perhaps the most difficult to assess and treat in our patients. We know that depression and anxiety are common comorbidities for all people suffering from chronic illness, including CF. It's estimated that up to 46% of people with CF suffer from depression and up to 33% suffer from anxiety, and these rates are significantly higher than the general population. We also know that comorbid psychiatric illness leads to poorer outcomes, such as reduced quality of life, increased healthcare utilization and costs, poorer adherence to medications, and even has been linked to reduced lung function and BMI. Anxiety and insomnia were included in the new drug application for Trikafta, again occurring in 1 to 5% of Trikafta-treated patients. But again, due to low incidence, it was not included in the package insert. However, this is again something that is commonly discussed in the social media platforms, on the CF Pharmacist listserv, and brought up by our patients. There have been a handful of different cases that were reported on in the literature discussing mental health concerns related to Trikafta, but in the interest of time, I'll just be going through 2 of those today. The first, by Hugh et al., described 6 patients that had mental fogginess within 3 months of initiating Trikafta. These patients had a slow onset of symptoms and described symptoms such as short-term memory loss, word-finding difficulties, and decreased reading comprehension. Notably, the patients were not on concomitant psychiatric medications when they started Trikafta and weren't on any other medicines that were known to cause altered mental status. And their symptoms were reported prior to the COVID-19 pandemic, so long COVID was not in the differential here, despite some of the similarities in symptoms. After reporting symptoms, 2 patients ended up needing to discontinue therapy to achieve symptom resolution. One patient initially self-reduced her dose, but then noticed an increase in her pulmonary symptoms, so she increased herself back to full dose, but flip-flopped the morning and evening doses, so did 1 blue tab in the morning, 2 orange tabs at night, and had symptom resolution with that dosing scheme. We had 2 other patients that attempted to flip-flop their doses, but did not have improvement in symptoms, so then went back to their regular dosing regimen. And the final patient did continue full dose Trikafta, and a month later noticed a 95% symptom resolution. The second case series by Spolatini et al. Reviewed the use of sweat chloride to assess a dose reduction protocol for patients that reported mental health side effects related to Trikafta, and I'll be reviewing that protocol here first. Patients had a baseline sweat chloride that was obtained before starting Trikafta, and then if they reported mental health side effects, they had a repeat sweat chloride that was obtained on full dose Trikafta, and then their dose was reduced to 1 orange tab in the morning, 1 blue tab in the evening, and 2 to 4 weeks later, they had a repeat clinical assessment to assess pulmonary symptoms and also get another sweat chloride on the reduced dose. And then based on that assessment and the sweat chloride, they changed their dosing further depending on the results. So if their side effect improved and their sweat chloride remained low, they continued on the 1 orange tab in the morning, 1 blue tab at night. If their sweat chloride was high, signifying a lack of efficacy of the Trikafta, or they had a return in pulmonary symptoms, their dose was increased slightly, either to 1.5 orange tabs in the morning, 1 blue tab at night, or 1 orange tab twice daily. And then finally, if they had a low sweat chloride, but their mental health concerns were still present, then their dose was reduced incrementally further to 1 orange tab in the morning and no tabs at night. And if they had further dose reduction or changes, they had another repeat sweat chloride and clinical assessment 2 to 4 weeks later. So of the 266 patients at the University of Leeds that started Trikafta, 19 of them reported mental health side effects, including anxiety, insomnia, depression, and brain fog. 12 of these 19 patients notably had a history of mental health related concerns before starting Trikafta. 13 of these 19 patients elected to undergo that dose adjustment protocol that are reviewed on the previous slide, while 2 elected to continue full dose Trikafta and were referred to psychotherapy, and 4 discontinued Trikafta at this stage. Of the 13 patients that underwent the dose adjustment protocol, most were F508del homozygous and were previously treated with tezacaftor ivacaftor before switching to Trikafta. And after undergoing the dose adjustment protocol, all had either a normal or borderline sweat chloride with their dose adjustments and had an improved pulmonary function or FEV1 compared to their pre-Trikafta baseline. 10 of the 13 patients had improvement in their mental health symptoms after undergoing the dose reduction protocol, whereas 2 of the 3 remaining patients ended up discontinuing therapy after going through this, and 1 patient switched back to ivacaftor single agent with symptom resolution. For the 10 patients that underwent the dose adjustment protocol, the doses that they ended up on are on the slide for your reference. So there are several different hypotheses as to why Trikafta may be impacting mental health. The first is that perhaps it's a direct effect of the CFTR modulator on the central nervous system. We know that CFTR is widely expressed throughout the central nervous system. The exact function is unknown, but perhaps Trikafta restoring the CFTR function could be leading to mental health issues in some patients. We also know from animal studies that ivacaftor and elexacaftor both cross the blood-brain barrier, and that ivacaftor and its metabolites have direct activity on and a high affinity for the 5-hydroxytryptophan 2C receptor in the brain. And this receptor has been linked to anxiety, depression, and other mental health-related concerns, and is a current target for antidepressant medications as well. However, it's unclear if ivacaftor's activity on 5-HT2C causes positive or negative mental health impacts, because there's actually been a study in mice that suggested it had a potentially positive impact, so more information is needed about this as well. And then finally, it's been proposed that perhaps there's a direct effect of elexacaftor, and this is because many of our patients were switched from tezacaftor ivacaftor to Trikafta, so elexacaftor is the only new molecule being exposed, so perhaps there's a direct serotonergic effect of elexacaftor, or it could be impacting another neurotransmitter, impacting mood. An alternative hypothesis that we must also consider is the psychological impact of initiating a potentially life-changing therapy. And this was explored further in an interesting paper by Ketchy et al. And they conducted semi-structured interviews in 20 patients, 17 of whom were treated with Trikafta. And they had complex reactions that they recorded to starting a highly effective modulator. Some of those included descriptions of things like regret for past decisions made with the assumption that they wouldn't live past middle age. Envy, disappointment, or resentment expressed by some that didn't tolerate or didn't have the response to Trikafta that they had expected. And even some reported things like survivor's guilt for having access to a highly effective modulator when there were those that still were not eligible or that had passed away before Trikafta came to market. So it's really important for us to also keep in mind these indirect impacts on mental health that our patients may be experiencing, and this demonstrates the need for psychosocial support upon initiation as well. Another hypothesis that has been proposed is perhaps this is related to drug-drug interactions, and this has been brought up based on our experience with lumacaftor ivacaftor. Of course, we all know that lumacaftor is a CYP3A4 inducer, and for people that had mental health-related concerns with after lumacaftor ivacaftor initiation, the hypothesis was that it was causing decreased concentrations of concomitantly prescribed psychiatric medications, such as SSRIs, which are CYP3A4 substrates. However, while elexacaftor, tezacaftor, and ivacaftor are all CYP3A substrates, they're not known inducers, and they're not known to cause significant drug-drug interactions with psychiatric medications. So I think this hypothesis is less likely for Trikafta. And finally, we must also consider that perhaps there's an alternative cause for worsening health that is just occurring coincidentally with Trikafta initiation. So it could be due to life circumstances, the stressors of living with a chronic illness, or even the worsening health that many experienced with the COVID-19 pandemic. However, I think this is also a little bit less likely for most of our patients because, again, many symptoms were described before the start of the COVID pandemic, and also many patients have described improvement in their mental health side effects if Trikafta's dose was reduced or if the therapy was held. So based on these cases and our experience in clinic, it's important that we should be counseling our patients on the potential for mental health related side effects after Trikafta initiation. And we also want to make sure our patients have up-to-date baseline mental health screening, such as with our PHQ-9 and GAD-7s before starting Trikafta. And for patients that have a baseline comorbid mental health concern, we should be encouraging close follow-up. If possible, it would be great to implement proactive mental health support upon Trikafta initiation, such as with online support groups or utilizing resources from our CF social workers or mental health coordinators. I also think it's important that we discuss mental health at each visit after initiating a CFTR modulator. And if patients have concerns, we should be referring to psychotherapy, referring to psychiatry as appropriate, or prescribing or adjusting psychiatric medications. And if need be, we can consider Trikafta dose adjustment or holding or discontinuation of therapy. So finally, what should we do if we have a patient coming into clinic that's presenting with a side effect that is not in the package insert? I think first and foremost, we as clinicians, we should recognize that there are side effects of Trikafta beyond the package insert, and that some that may not have even been reported on in the literature, and we should be validating our patients that it is a potential, it could be related to Trikafta. And we should be taking a detailed history of the side effect, assessing the timing of onset of the side effect compared to when Trikafta was initiated, and seeing if there's been any mitigating therapies. Does the side effect improve if Trikafta dose is reduced, or if the therapy is held? Are there other alternative causes for the side effect outside of Trikafta? Of course, we can do a more formal causality assessment using one of our validated adverse drug reaction assessment tools, such as the Naranjo ADR probability scale, which, if we remember from pharmacy school, it's a 10-item questionnaire that assesses that the likelihood of a reaction is related to a drug. Also, it's very important that we should be reporting any suspected side effects due to Trikafta to Vertex or FDA MedWatch. And also, we should be discussing these with our colleagues on the CF listserv. This would better help us recognize patterns of side effects across CF centers, and also could potentially help us collaborate on future case series so we can more widely disseminate this knowledge as well. And of course, we should be creating an individualized plan with our patient to see how we want to manage this side effect, keeping in mind how severe the side effect is or how distressing it is to the patient, what the pre-Trikafta baseline was, and how much benefit has been seen with CF symptoms after initiating Trikafta, and also with discussions with our multidisciplinary team, and keeping in mind patient preference as well. After we keep all of these in mind, we may decide to continue therapy with supportive care or treatment of the adverse effect. Keeping in mind full dose therapy may also include flip-flopping that morning and evening dose. We may decide to reduce Trikafta if need be, keeping in mind we should be following up closely, and we can consider using our sweat chlorides to assess the efficacy of that dose reduction. And finally, if need be, we may have to discontinue therapy with close scheduled follow-up, either completely discontinuing modulators, or if applicable, going back to a previous modulator that was tolerated by the patient. So our key takeaways for today are we want to recognize newly identified adverse drug reactions that have been published since Trikafta came to market. Some of them that I reviewed today: testicular pain, cholecystitis, hypervitaminosis A, acne, and mental health changes. We also want to update our Trikafta counseling and follow-up to include these newly identified adverse reactions. For patients that present with adverse reactions, we want to manage via a shared decision-making model and close follow-up, and remember to report all adverse drug reactions suspected to be due to Trikafta to Vertex or FDA MedWatch. Thank you.
Next, I would like to introduce Laura. She's going to go through our copay models.
Good morning, everyone. Thanks for being here. I have no disclosures for this presentation. So hot topic right now, I think we're all dealing with is these copay accumulator programs. So these are a feature program within an insurance plan whereby a manufacturer's payments do not count towards patient's deductible or out-of-pocket maximum. The manufacturer's copay card, copay funds, they do not count until the maximum value on the copay card is reached. After that, the patient's out-of-pocket costs begin counting towards their annual deductible and out-of-pocket maximum. These started being introduced in 2018 by several of our pharmacy benefit managers. So the barriers that we're seeing is most of these programs have maximum limits of assistance per year. With the copay accumulator programs, once that max has been reached, the patient may face a very high copay. Patients and families then can experience extreme financial burdens, not only affecting their ability to afford their prescriptions, but, oh my goodness, but also other essentials such as food, gas, and utilities. This can lead to treatment abandonment or non-adherence if medications are unaffordable. This has the potential for negative health effects or potential decline in health. So, what can we do to help our patients? Biggest thing is to inform families of these programs and help educate them to investigate whether their insurance utilizes a copay accumulator. And then what I like to do is really empower families who are covered by employer-sponsored plans to speak with their human resource department about these downfalls. This could be potentially considered when employers investigate which insurance company they wish to utilize when open enrollment is available, which that's where we're at right now, I think, for the most part. And then take legal action and empower families to do the same. I know I have a lot of parents and families that are willing to do that and contact their state legislators. And then a lot of states have already enacted laws banning copay accumulators. But what we really need is this to be on a federal level. And if you're not aware, there is a bill that's been introduced to the House, and it's called the Help Copays Act, or HR 5801. This was introduced by Donald McEachin from Virginia on about a year ago, November 1st, 2021. It's not been voted on yet. So you can go to congress.gov and look up that bill. There's a button to search for your state representatives and then contact them asking for their support. I've done that, and then I've kind of put a bug in my coworkers' ears to do the same. And then you can also click to get alerts of kind of where it's at once people have also, legislators signed for supporting that. This bill, once passed, hopefully, would be on a federal level and require insurance plans to count towards copay accumulators or copay assistance, to account towards financial assistance, copay assistance, and the plan sharing, cost sharing requirements, which isn't happening with a lot of plans. So this is an example of copay accumulators. The top is a historical example, or if it's not, a copay accumulator plan. So as you can see, that top line, okay, it's bigger over there, good. So the first fill is going to be the deductible. So this is an example, a patient has a $2,000 deductible, and then they have a 20% co-insurance, so it goes down to $400 after that. And then they have a $4,000 max out of pocket. So after 6 fills, then the patient would not face any copay. But then down at the bottom, this is a copay accumulator program. So every fill, copay assistance is responsible for $2,000 because they're not meeting any kind of deductible. So that copay assistance is having to pay $2,000 each month. And that's the concern with patients potentially maxing out their copay assistance. Oh, darn. It does look bad, sorry. So we've heard a lot recently about Vertex copay assistance changing. This is going to go into effect the 1st of 2023. The biggest thing is there's now going to be an annual max of $20,000. If a patient has a plan with a copay accumulator or maximizer, they're only going to get $3,500 per fill on their modulators. If they don't, they will get $8,950 of copay assistance per fill. One caveat that we do need to make sure they're aware of is they're going to have to submit an attestation form to Vertex GPS. You could reach out to your contact to get that form, or just let the patient know to reach out to the Vertex GPS contact. There is an option for patients to submit for direct reimbursement from Vertex GPS. You can also reach out to your Vertex GPS contact for more information on this. That could be a potential workaround with these copay accumulators, but at the same time, my concern is, do patients have the ability to pay their copay and then get that direct reimbursement? So. And then going into matrix models or formularies. So under a healthcare plan, the list of covered prescriptions is called a formulary. So formularies are divided into tiers or levels of coverage, and this is based on many things, such as the cost of the drug, the drug and how it compares to other drugs for the same treatment, drug availability, the clinical effectiveness and connection to standard of care, other cost factors including delivery and storage. And then I just have a showing of kind of the tiering levels. Higher the tier, the higher the cost. And then barriers here. So medications prescribed by provider that are not on the formulary, prescribed medications being on a higher tier level and potentially unaffordable for patients. Insurance formularies try to dictate which medications need to be tried and failed before they will pay for another, thus taking away from the provider's clinical judgment. And insurance companies do not always take into consideration age and/or formulation appropriateness of medications. I see this a lot, especially with our inhalers. You know, they in our pediatric population might want like a discus formulation, so we have to fight with them and send in studies or something like that to let them know that we do not use anything but like a HFA because of the particle size. So what can we do to help patients in this case is educate them to review their plan's formulary every year during open enrollment to ensure their medications that they are on will be covered. And if insurance does not want to cover a medication a provider has prescribed, an appeal may be necessary. First, ensure other alternatives are truly inappropriate based on age and formulation. You may need to look for supportive studies and write a letter of medical necessity if an appeal is necessary. So in conclusion, insurance can be very confusing and frustrating, as we all know, not only for patients, but for all clinical staff involved in the prescribing process. As part of the CF care team, we can help to educate patients and families about these coverage challenges so they can be better prepared. If patients do get into financial binds due to these coverage challenges, explore other avenues for assistance, such as copay assistance grants, patient assistance programs. Thank you.
Next up, I'd like to introduce Dr. Megan Fleischman. She's going to talk to us about aging.
adjust a little bit here. Let me know if you can't hear me well. So as you see, I have nothing to disclose. I do want to say thank you to Hannah and Renee for setting up this entire session. They've done great work with it. I also want to thank the CF Planning Committee for the invitation to speak and for bringing us all back together again. So my presentation today, if my thing works, there we go, is going to be on hypertension, hyperlipidemia, and osteoporosis. This is a lot to cover in our limited time frame here. So what we're going to do is we're going to just do a brief description of screening, as I imagine many of you have implemented screening for these conditions in your clinics already. And then we're going to also be brief on when to treat, as typically the CF team is not the one treating these conditions, but I want to empower you to have the knowledge to encourage patients to get that follow-up, because sometimes the CF team is the one reminding our patients, hey, maybe you should make this follow-up with the treating team. And then, since this is a pharmacy focus session, we are going to review the common medications as well as advise on consideration of use of these medications in someone with cystic fibrosis. I am going to take a little sidestep from the PowerPoint right now to mention how this is a near and dear topic for me for two reasons. One, I come from primary care as my background, so I spent my first 4 years there. So prevention and managing these conditions is top of mind for me often. Also, I want to share a patient story with you. So we'll call this patient Noelle. So Noelle is a patient I became rather familiar with soon after my starting at the CF Center, the Adult CF Center, because she was somebody that had a pretty quick decline in lung function pretty soon after I started. She was having several exacerbations, therefore requiring the pharmacist to be involved with home IV monitoring. Also, she had a lot of complications with her CF, in addition to the fact that she's human and she has other medical conditions that also had some complications. She was often on more than 50 medications. Therefore, lots of times for me to meet with her to clean up that medication list and review drug interactions. And then we were able to send her in for theratyping, and she did match, or she did respond to a CFTR modulator, so I was involved in getting that approved. And then when ETI therapy came out, she was also responding to that and able to be started on that therapy. So her frequency of exacerbations did improve with modulator use. However, they were still relatively frequent. Everything in her picture suggested the typical CF pathway, or the stereotypical CF pathway, where her mortality would likely be from respiratory failure. Or, of course, we'd go the transplant route before that point. We had a visit with her in the spring, and we've had several visits, but at that visit that I remember, she was doing really well. She was breathing really well. Things were going well from a respiratory standpoint. A couple days after that visit, we got a call from her family. She had passed away from a heart attack. She was in her upper 30s. Noelle was a huge advocate of managing cystic fibrosis, of managing your lung therapies. She did a lot of fundraising. I would like to think that she'd encourage me to share her story to emphasize the importance of prevention and help us think about managing these other conditions. She did have risk factors for cardiovascular disease, as we'll learn about when I discuss hyperlipidemia. And as far as CF goes, there may be a possibility of an increased risk of cardiac complications just from having CF, but that's really based on case reports and some biomarker studies. So not a lot of robust data, so a lot of that's still unknown. We do know, though, with osteoporosis, our patient population is at a higher risk of developing osteoporosis. But we're also seeing, with highly effective modulators, less pulmonary complications right now. And as our population ages, and we're hoping to see less pulmonary complications as our patients get older. Therefore, we're hoping that we're going to have to be managing these conditions because risks may be there, whether it's because they have CFTR dysfunction or not. We're going to be seeing patients in their 40s, 50s, 60s that we want to be managing these conditions and be aware of it. So let's start with a more familiar topic of osteoporosis. And it's more familiar, the CF Foundation has a guideline out there for us to follow as far as screening and management. So for the pediatric population, everyone who is 8 and older with a risk factor should be screened, and then everybody who's 18 and older should be screened. And that frequency of screening after that initial screening would be based on what their DEXA scan shows. I'm going to add in the National Osteoporosis Foundation's guidelines as well for our postmenopausal population and our males over the age of 50. I would default to the CF screening because it's more conservative and our patient population coming into this has already been following this screening pathway. But when to treat has some other considerations for this group. So you may want to take into consideration a FRAX score, for example. Again, we're not necessarily going to be the ones doing the treatment. We'll be more so having a lot of other treatment teams involved. But often we are involved in making sure there's adequate supplementation. So this is very essential in managing osteoporosis or even osteopenia. So making sure we have vitamin D, vitamin K, and calcium adequately supplemented. And you have this table to reference for the calcium supplementation. So elemental calcium, being specific to dietary, is the ideal way to get it. But sometimes our patients, especially with CF, will need that additional elemental calcium. When it comes to the other medications or the drugs used for it, these are the categories that have data in CF. So our bisphosphonates, their mechanism of action is to inhibit osteoblasts to decrease bone resorption. Parathyroid hormone analog works to activate osteoblasts, and that increases new bone formation. And then the sclerostin antibody works by targeting sclerostin, which is in bone metabolism, to increase bone formation and to a lesser degree decrease bone resorption. So on this busy slide, I have the list of the different doses that have been looked at in patients with CF. I'm not going to read this all to you, but the duration cap comes from the idea of safety. So for the bisphosphonates and the sclerostin antibody, their risk is osteonecrosis of the jaw, and they've seen more atypical fractures if we've gone beyond these duration caps. And then for teriparatide specifically, there is an increase of osteosarcoma if used more than 2 years in an entire lifetime. So when we take into consideration the use of these medications in people with cystic fibrosis, thinking about the oral bisphosphonates, they have a lot of GI implications. So that's something to consider because we don't necessarily want to be thinking, oh, now they have these new GI symptoms that are occurring. Could it be from the medication? Trying to avoid treating symptoms that are occurring, thinking that they're from CF complications, and rather looking at, is it a medication side effect? Woo, this is fun. We just wanted to make sure everybody was awake. Maybe we should do a stand-up exercise for a second there. The other part of oral bisphosphonates is that they need to be taken anywhere from 30 to 60 minutes before food, drink, pretty much anything except for a large glass of water. It is product specific on the duration beforehand. I will mention that delayed release resendronate is an exception to that. It should be taken with food, but if you look at the bottom of our slide here, you'll see that it does interact with PPIs and H2RAs, so a lot of our patients tend to be on that medication, and we really shouldn't be using it due to the interaction and increased concentrations of the medication. If we decide to go the intravenous route to avoid the oral issues, then we do want to keep in mind that it has been reported to have a more severe acute phase reaction in patients with CF, so often they will need pretreatment for the infusions. The other part is bisphosphonates have a long half-life in the skeleton, and so that's something to consider as far as those adverse effects mentioned, but then also if there is family planning going on, then you would want to ideally have the patient stop the medication about 2 years before becoming pregnant if they wanted it to be completely eliminated from their system. And then the other relevant drug interaction is the additive risk of nephrotoxicity and GI ulcers, specifically with chronic high-dose NSAID use. As far as our parathyroid hormone analog, just as an FYI, after that 2 years of therapy, usually an anti-reabsorptive therapy will be started to kind of hold in that effect of the bone formation. This also should be considered to be stopped if pregnant. It is going to be a benefit versus risk discussion, of course, but it does have that shorter half-life where it can be stopped even after finding out somebody's pregnant or right before with family planning. And then as far as adverse effects, again, having some of those similarities to what we'd see as complications of CF. So we know people with CF have a higher tendency towards hypercalciuria, nausea, dyspepsia, dyspnea. So again, avoiding thinking that these are complications and really looking at could this be the medication. And then for the sclerostin antibody, this requires adequate calcium and vitamin D supplementation like all the therapies. However, a bigger emphasis to make sure that it's corrected before and while on therapy because it does have a very high risk for hypocalcemia. This is also contraindicated in women with reproductive potential. And it has a black box warning for myocardial infarction and stroke, so we can't use it in somebody that's had one of those in the past year. But our next two topics, we're going to work on making sure our patients don't have these complications, right? Or at least trying to prevent them the best we can. So looking at hypertension, there are no recommendations specific to people with cystic fibrosis. However, in general, screening should start annually, at least starting at age 3. And if there's risk factors, every visit's ideal. One of those risk factor examples being CF-related diabetes. When we treat people for high blood pressure, well, with the pediatric population, we really want to try and get them to goal with lifestyle modifications. But if we just can't, then we consider starting medications. Here we go. Now everybody's awake. Now we can rest a little bit more. Good. I appreciate the lighting effects, it's great. For adults, we have 3 elevated blood pressures, and really one of them should be gathered as elevated outside of the clinic setting. And then we'd start medications. And those medications, there's lots of medications, but the first line groups used are going to be our calcium channel blockers, ACE inhibitors, ARBs, and thiazide diuretics. So as far as considerations for their use in people with cystic fibrosis, our dihydropyridine calcium channel blockers really are going to be the one that most common practice will use first line. It's going to be rare that you'll see non-dihydropyridine calcium channel blockers used first line, but it's not technically inappropriate. So if you do have somebody that really likes to put their patients on that as first line, we do have implications for our patient population with CF. And that would be that they're moderate CYP3A4 inhibitors, so we'd have to adjust our modulator dose. And there is verapamil that has that side effect of constipation. For ACE inhibitors and ARBs, they do have a risk of added nephrotoxic effects with NSAIDs and certain antibiotics. And then for our thiazide diuretics, they actually have some agents that have evidence at normal antihypertensive dosing that they can reduce calcium-containing kidney stone formation. So maybe we'd have a little bit of a preference for this if we have some patients that have a tendency towards hypercalciuria or kidney stone formation, or maybe we just prefer this in general. For the interactions with other medications, NSAIDs, there is a potential for reduced therapeutic effect. So if we do have somebody chronically on NSAIDs, maybe we'd shy away from this group. Or if we're seeing less of an effect, we would consider changing. And then there's the added nephrotoxic effect. And then if patients do experience hypokalemia, keeping in mind that that does increase the risk of QT prolongation with a lot of our agents that we already are commonly using that can increase that risk for QT prolongation. And that brings us to hyperlipidemia. So again, for this, no recommendations specific to people with cystic fibrosis. Actually, really no solid recommendations for primary dyslipidemia in the pediatric population either. It is being looked at, but there's nothing for primary dyslipidemia. The other dyslipidemias, yes. For CF-related diabetes, however, if they do have that, they should be screened annually if they have a risk factor of obesity or a family history of coronary artery disease or are post-transplant. And then adults who are 20 years and older should be screened every 4 to 6 years if they have a risk factor for ASCVD. And those risk factors are lipid abnormalities, biomarkers that are tied to an increased risk of ASCVD, a family history of early coronary artery disease, high-risk medical conditions, which would include metabolic syndrome, early menopause, pregnancy conditions that have been linked to ASCVD later in life, CKD, and then chronic inflammatory conditions. So would this make us think we should be screening our patient population every roughly 4 to 6 years for dyslipidemia? So once we have that screening, we can decide how to treat. And well, actually we don't need screening to treat them. If they've had an event, we need to put them on a statin. So these are our 4 statin benefit groups, people who should be put on a statin. If they have very elevated LDL cholesterol, they should be put on a statin. And if they have diabetes and are between the age of 40 to 75 years of age, they should be put on a statin, and the level of intensity is going to be based on certain risk factors. I will also note that if they are between the age of 20 and 39, a statin should be considered, particularly for those people who have a risk for or evidence of macro and microvascular changes. So that would be your people with retinopathy, CKD, people with peripheral vascular disease or peripheral neuropathy would be examples of those. And then for our CF population, that duration of diabetes, so 20 years or more, would be another time where I'd want to kind of consider, should we think about a statin? And then for our last group, so if they don't have any of the above 3 situations and they're between the age of 40 and 75 years of age, an ASCVD risk calculator should be used. And again, we're not the treatment team, we're probably not calculating that, but if you want to really sell that point to make that treatment follow-up, you could find the calculator. It's all over the place online. Just type in ASCVD 10-year risk calculator, or there's an app for that. And so with that, then again, based on their risk score, you would decide to start either moderate or high intensity statin. And so when I say moderate or high intensity statin, how that is defined is based on their LDL lowering ability. So a high intensity statin, on average, lowers the LDL cholesterol by 50% or more. And these are lists of the examples and the doses that they come as. When we think about statin use in our patients with cystic fibrosis, we know that statins have rare case reports of liver enzyme elevation and hepatic failure. It's rare, but a lot of you now have flags going off in your brain and you're thinking, CFTR modulators have that same effect. So you're right. That's why we're going to take this into consideration. There's no strong evidence like you have to do this amount of monitoring with the combination, but it would be appropriate to be more conservative with your liver monitoring and considering if they have liver disease at baseline, if they are going to be put on both agents together. And then again, our CF population doesn't necessarily have myopathies as a presenting factor, but they do have characteristics that align with people when put on a statin may be at higher risk for myopathies. So thinking about a smaller body frame, multi-system disease. We know a lot of our patients will use physical activity to help with airway clearance. And then multiple medications, not really any that I think of that have myopathies as an adverse effect. However, the drug interactions, antibiotics, antifungals, CFTR modulators. So when we think about those characteristics of statins that have a tendency towards myopathies, it's going to be those agents that are more lipophilic. And then we know that ivacaftor is a weak inhibitor, but does have inhibition of CYP3A4 and 2C9. So there's no statin adjustments that are needed, but it may have that slightly higher concentration that just increases that risk factor for myopathies. So this is a table available to you for if you're ever consulted on, hey, what would be a better statin that we could use because my patient is having more issues with myopathies. Again, trying to think about can we switch agents rather than have to treat the side effects. So that gets us to our takeaways, which we want to evaluate for possible side effects and drug interactions to avoid adding more medications to treat adverse effects. And I know in CF and transplant, sometimes we don't have another option and we have to treat the side effects. But in these other conditions, we probably do have another option that we could switch to. So taking that into consideration. And then malnutrition, inflammation, several other factors contribute to an increased risk of cardiovascular disease and reduced bone density in people with cystic fibrosis. So we may want to consider a more conservative approach, at least with screening, probably being a little bit more aggressive with therapy. Then again, with highly effective modulators, maybe some of these risk factors will not be as big of a risk or not be something our patients are experiencing as much. And so if that's the case, then maybe not. So looking at that idea of having that discussion with our patients, what don't we know? What do we know? What do we maybe not know in CF, but we do know in general? And ultimately coming up with the best plan for them. So I thank you for your time and attention, and that brings us to our last portion. Give it back to Hannah and Renee.
Okay, so if I could ask all of our speakers today to come up on the stage, we're going to take questions. I have a couple of questions already from the app. Some people are more tech savvy than others. First question that I received, of course, from a dear friend. What is the possible mechanism with ETI and contraception and rash? So if there are any others in this room who have more experience or have a better explanation. So in the literature and in the case reports, there hasn't been as much detail in terms of talking about that interaction and the mechanism, the pharmacology behind it. But if we think about hormone fluctuations, for example, in menopause, when we have a drop in estrogen, some of our patients who go through menopause may undergo itchiness, rash, hives of the skin. And we're more sensitive to things like detergent and lotions. So that is in my mind, just the HFON theory, is that maybe ETI is causing interactions and drops and changes in our estrogen levels and causing that. So that is my theory, but I welcome anyone who has any additional pharmacological theories that may be attributed to that rash interaction. Anyone? No? Okay. I've seen plenty of males and young males have the rash. So the complete understanding of the etiology of the rash has yet to be further elucidated, but hopefully we will learn more about that with additional case reports and literature. Another question, and this is directed to Laura. Can you clarify why Vertex would have a lower max monthly benefit for people with an accumulator than without?
So I don't know if you all saw the communication from Jenna Harrington. Are you Jenna? Hi, Jenna. So they are being very, I love that you guys are, the communication that you do not want anyone to discontinue the treatment. I encourage you to reach out and have a meeting with them. I already did, and the dialogue was wonderful. These plans in the copay accumulators, they're terrible, and it's really stressing these programs, the copay assistance programs, to have to pay a lot of money from them. And so what has happened is just that, is Vertex is having to pay a lot of money to these PBMs, or pharmacy benefit managers. So that is what I took away from that meeting, is they kind of, their hands were tied. They are having to pay a lot of money, and so they evaluated that and came up with this plan. When I was in that meeting, I kind of said, I've never seen a split like this, where they are doing one thing for patients with a copay accumulator and something else for patients that don't have it. So that is my biggest concern here. But yes, I think it's just that there was a lot of money that they were having to pay for patients that had the copay accumulator plans. Does that answer your question? Or can I elaborate any more?
All right, thank you. This question is probably directed to Julie. Are repeat sweat chloride testing, is that covered by insurance?
That is a great question. I am not 100% sure of that answer. We, at my clinic, have not done a ton of repeat sweat chloride. I think when we do, we typically coordinate with our pediatric center as well. I don't know if anyone else in the room has knowledge about insurance coverage with repeat sweat chloride, but I am not sure of the answer to that question.
We've done some.
Yeah.
We haven't had trouble with
Okay, great. So Laura says that they have not had trouble coverage at their center, so hopefully that would be the experience, but it may be individualized depending on the patient's insurance as well.
And since you're already up here, question is, can you elaborate on hair loss with ETI and possible causes and solutions?
I think that's a great question. That's something that has been reported by a handful of patients that I've had experience with. The patients that I've seen with hair loss also had other side effects that they attributed to Trikafta as well. Several of them reporting kind of hormonally related side effects. So the question that came in my mind was, again, is there a potential hormonal off-target effect of Trikafta that we're not sure about yet? So we definitely need more research and information to see why hair loss may be occurring. We had one patient that had significant hair loss and ended up being seen by dermatology, and she ended up having an alternative diagnosis also as a potential for her hair loss as she was going through a period of extreme grief after the sudden loss of her father. So that was thought to have played into that as well. So we should also examine alternative causes, but I definitely think that there is an association of Trikafta and our modulators with hair loss. I also have had a few patients that were on previous modulators like ivacaftor that experienced hair loss as well. So I think we need to look into that further, but I think maybe there's a potential hormonally related component just based on some of my female patients that experienced other hormonal related side effects along with that.
Thank you. All right. A question for Megan. Thoughts in terms of maybe a proposed frequency of monitoring when doing concurrent statins and modulator in terms of like liver function and whatnot?
Yeah, so as I mentioned, there's not really information out there on it, but I would kind of base it on I'm guessing we wouldn't be starting them at the same time, right? I would base it on what's being started. So technically statins don't have any liver monitoring requirements at all. They used to a long time ago, but they took that away because people were being discontinued and not restarted on their statins way too often for considering the low risk of actually developing liver disease. So I would say I would probably check 1, 3, maybe another time months out after starting a statin just to make sure liver function's okay if they've been somebody already established on a modulator. And then for modulators, maybe I just stick with the same frequency, or really I would probably do just like an extra, make myself a little bit more comfortable, check at 1 month after starting the modulator if they're already on a statin. I think that's going to be a rarer population that we come across, but that's That's just my own clinical judgment. I'm willing to hear other clinical judgments and thoughts on it as well.
Okay, I've received a couple of questions about desensitization, and I welcome, there are a couple of the co-authors of the case reports in this room, so if y'all have extra insight, please speak up. For patients undergoing desensitization, are there any insurance coverage considerations we need to consider, especially if compounding pharmacy is used? In the scenario that I had at my center, insurance was being very challenging in terms of coverage. We had to write an elaborate letter to even consider, for them to consider, and it's still being reviewed for desensitization because it's coming from a compound pharmacy. But I do know, from what I understand, Dr. Autry at Kentucky, you guys took on the compounding as part of like the process for a couple of the cases you guys published, correct?
Yes, that's correct. We're fortunate with University of Kentucky College of Pharmacy, we have some resources available. The primary thing is the patient does come to our center for initial consultation with our allergist. That Dr. Kuhn and I take on the compounding.
It is the art of pharmacy.
And we've had patients referred to our center for desensitization that in other institutions trying to partner with a compounding pharmacy, it was going to be like tens of thousands of dollars because they wouldn't use patient on supply to do the compounding. They were going to have to get drug through alternative means. And I don't know specifics of our one case. It's actually in the Northeast, had the patient advocated and found a compounding pharmacy. We partnered kind of remotely to build that desensitization.
Wonderful. Thank you so much. Another question. Oh, yes. Yes, Dr. Kuhn.
So, it seems to me that we are in a crossroads. We're seeing more and more side effects. If you really think about desensitization, true desensitization, it requires that sequential
Yes.
approach. Now, these other approaches may work in some patients, so it seemed to me that half-tablet. Remember, the FDA says there's no uniformity of tablets, has to be guaranteed.
Yeah.
Plus or minus 20% for an oral tablet. Figure that out when you're trying to desensitize somebody, okay? So we have all these things that we can fix, I think, down the road. But we need to put our heads together and do this. And what's the crazy part about it is the company can't help us because of FDA regulations. And we're all trying to do this on the fly, okay? Or you need a $3,000 columns to do these aliquots, a really sophisticated one. So it just seems to me that we can work together and try and share these things, but it often works. The sequential half-tablet, what's an 8-foot tablet? Somebody show me how to do that.
Right.
Okay, we don't do that in Kentucky, all right? Do bourbon, but not 8 tablets. No, but I mean, I think we really are all working together to try and solve these problems, and the speakers talked about so many things we're now starting to see because we've got 15,000 to 20,000 patients on these drugs. And we're starting to see that, and they're getting older like me, which is all good. So I think we need to do that. Now, I think we need to do some stability studies. If we're going to put it in a suspension, because this drug's water insoluble. The other problem is when we desensitize somebody, we'll desensitize them to 3 drugs. It's not 1, it's 3.
Right.
And we have no HPLC assay to do this. So there's a lot of things we can do. And I'm sorry for being so passionate about it, but we waited 25 years for this, or 30 years, and we're there. We just got to fix it. Sorry.
Yes.
Our desensitization, I work with pediatrics, and this was for an adult patient, but I just went to my friend in the pediatric pharmacy who comes all the time. So maybe you can find your pediatric pharmacy colleague and see if they'll help you out. But we did it with patient on med and just.
Yeah, there's also implications of taking on patient-owned med and if your health system's cool with you compounding it and whatnot, and if something goes wrong. Just to put that out there.
We've partnered with that have reached out for guidance. They're usually partnering with like maybe their inpatient pharmacy colleagues or something to do the compounding and work through those things. But we've got it down to quite the science, you know. A couple of hours we have it done, and are getting a lot of referrals. And really had 6-year-old
Yeah, awesome. All right. And I think back to Julie. For adverse effects not requiring discontinuation, dose reductions were mentioned for Trikafta. What are some recommendations for dose reductions?
We take, at the University of Pennsylvania, we take an individualized approach to the dose reductions that we do depending on the severity of the patient's symptoms, but I think I've liked what I've seen at other institutions as well with a more protocolized approach with dose reductions. Typically, what we'll do is similar to the description that I showed with the University of Leeds, where we do 1 orange tablet in the morning, 1 blue tablet in the evening, especially for our patients that tolerated Symdeko with no issue and then switched to Trikafta. The thought being that maybe we need to reduce the elexacaftor exposure, so reducing that orange tablet. However, we've had more unique dose reductions that we've done for some patients that had significant side effects or that were more reluctant to stay on therapy. Usually it's the flip side. Most of our patients want to stay on the highest dose or amount of therapy as possible, but we have had a handful of patients that were reluctant to restart because of side effects. So we may hold the therapy until side effects have washed out for a little bit. And then we've started even as slow as doing the full dose spread over 3 days. So 1 orange, 1 blue, 1 orange, 1 blue, dosed daily to kind of spread that dose out for the patient. And some patients have had benefit and liked that dosing scheme. It helped them also remember and stay on that dose a little bit easier as well. So we've varied it quite a bit depending on how they responded.
Great. Thank you. Okay, another question that we received, this one's directed for desensitization. Do you have any thoughts on washout periods of previous modulator prior to starting ETI? We've seen more rashes in kids who transition from Orkambi to Trikafta than those with starting Trikafta fresh. First and foremost, the individual asking the question, please publish your findings. If this is a trend that you're seeing, please look back and summarize it and share it and disseminate in the literature, because as you guys have seen, like the case reports that come out, it helps all of us learn what we're seeing out there in terms of trends. In terms of like a washout period, if you're starting to see that with like the Lumacaftor, Ibracaftor, and then switching them to ETI, you could consider a washout period, but I do caution like coming off of modulator and giving them that washout period, the risk of increased symptoms, exacerbation risk, things like that. So depending on your patient in terms of where they stand in terms of lung function and how severe their pulmonary symptoms are, that's something to consider as well. Any other thoughts on that from anyone else in the audience? It's like open discussion. Yes, Dr. Artry.
I guess for the first case, Patterson et al. That we were involved with, this particular patient was on Lumicaftor, developed rash, re-challenged, still had rash. So again, that modulator was really held at that point. Did Tezaiba develop rash, again, re-challenged, and thinking common things common is probably all the Ibracaftor component. So for that original desensitization, it was just building up the Ibracaftor component and then successfully transitioned to Tezaiba and was very stable. Thinking again, Ibracaftor was always maybe the common culprit for that particular patient for the Linhart et al. Against the patient. We just went straight from Tezaiba to triple combination, thinking again, common things being common, it's probably going to be the Ibracaftor component. But I know there's some kind of case reports, publications that are out there
thank you. Yeah, definitely on a case by case. Again, if you guys are seeing different adverse effects, maybe some patterns in terms of how they're arising, please share. And if you are able, disseminate it in the literature. Any other questions from a verbal? Oh, wait, new question. Let's see. This might be a Julie question. Has anyone been doing, or have you seen any literature on cytochrome P453A4 pharmacogenomics testing in patients with severe side effects incidents? Is it higher in the CF population?
We haven't done any testing in our patients regarding if they have any mutations or anything that would change their CYP3A4 metabolism, but I'm not sure if anyone else has experience with that. We haven't personally. Dave?
Yeah, we did a pharmacogenomic study with people, publication pending, but it appears that the CYP3A4 is similar to people without CF. The 2C19 and 2D6 do seem to be different in people with CF than not CF, so those enzymes are less involved with drug interactions, but not zero. So stay tuned, publications coming.
Cool.
Interesting, thank you.
All right, thank you. All right, any questions from our group here? It's a great showing on the first day. This room is full. I remember 14 years ago, my first NACFC, fraction of folks. Oh, another question. This one is directed for Megan. What osteoporosis meds, if any, are preferred for women of childbearing age or who may want to become pregnant in the next few years?
I don't know that there really is a good solid answer. I think that's going to be more of a discussion of risk versus benefit, like how severe is their osteoporosis. I didn't see anything in the literature that solidly says that. Does anybody else in this vast room of knowledge know that readily? So, I mean, if they want to, in the next couple of years, I may be a little bit more partial to teriparatide just because you can stop it if we do want to get some bone formation going on. But I think that's going to be really a discussion of looking at that person as a whole, what their goals are, how bad their bone density score was. That would be all factors I'd take into consideration. Bisphosphonates are technically, like, they have complications, so that's why it's the risk versus benefit conversation, but they have been used in that younger population, and there is a little bit of data in pregnancy, unfortunately. Again, there's fetal complications with it. So risk versus benefit is where we go to.
All right, thank you. Let me just double check both technology applications to make sure I haven't missed any questions. In the meantime, if anyone has any questions, please, we have the rest of this time. I wanted to make sure we had sufficient time for questions. All right. Again, thank you everyone for coming this morning. I know it was a little bit rough for those on the West Coast. Dr. Kuhn, yes.
Can I make an announcement?
Yes.
So just so everyone here, Dr. Young and Noble and the Utah group and the Kentucky group are revisiting this pharmacist survey that was done, 10 years ago? Almost 11. So this is really helpful, I think, to help. David's led an effort to help pharmacists become essential members of the team, I think they already are. But, so we have a survey, we have a QR code here. So if you're a pharmacist or a pharmacy technician who's working in a USCF center, we encourage you to get one of these. We're going to send it out on the list the next day or so as well. So if you're stuck in the airport somewhere, waiting for a cup of coffee at Starbucks, you can do this in 10 minutes, okay? And I have a bet with Paige Road, who's our pharmacy resident, who's leading this project, how many will get done by Monday? So don't make me look bad. We have several happening, so we'll be passing about the sessions and you take one of these. I'm not running for Congress, I just want you to thank you.
Yes, another question in the back?
I have one more. I just wanted to say hi briefly. Laura referenced me. I'm Jenny Harrington. I run the Vertex GPS program. So we are making changes, as Laura very expertly reviewed. There have been some questions, concerns amongst the community about the changes we're committed to ensuring access for every patient and ensuring no one discontinues. It's an unfortunate situation with what the payers are doing. We're working with them to educate on patient harm, but more importantly, we work with each and every patient. If you aren't working with us yet and you want to meet, please come over. I'll give you a card. We're here at the meeting. I just wanted to make sure that anybody, if you don't know about them or if you have concerns you haven't addressed, that you can come our way and we can help out because we're committed to doing that.
All right, thank you. And then one last announcement. We have our pharmacy symposium session, which is going to be in room 114. So if you're able to come and go, please come. It should be a great session led by our colleagues. And with that, I will adjourn this session and give you guys a few minutes left in your morning.